This is the ABCs of thyroid cancer, understanding key terms, concepts, and initial diagnostic and treatment steps with Dr. Desai. Dr. Desai is an endocrinologist and clinical assistant professor of endocrinology at Stanford University in Palo Alto, California. She completed her endocrinology fellowship at the Mayo Clinic in Jacksonville, Florida, with an emphasis on the management of patients with thyroid cancer. Dr. Desai's clinical practice, located in the Endocrinology Clinic, Hoover Pavilion, Palo Alto, focuses on the management of patients with thyroid diseases, including thyroid nodules and thyroid cancers, and the management of patients with pituitary disorders. She also maintains board certification in neck ultrasonography and internal medicine. Thank you, Dr. Desai. Welcome.
Thank you so much. I'm so excited to be here. This is my third year at ThyCa, and I'm actually giving 2 talks this year. So I gave a talk earlier on pregnancy and thyroid cancer. And now I'm going to go back to the basics. So the ABCs of thyroid cancer, understanding key concepts, terms, diagnosis, and treatment. It's important to know these things to advocate for yourself and to participate in your own care. I'll take questions at the end. Topics I'm going to cover today. So we will briefly review what the thyroid gland is, anatomy and some physiology, how it works. And then I'm going to talk about thyroid nodules, because you have to talk about nodules before we get to cancer. We'll talk about how thyroid cancer is diagnosed, the different types of thyroid cancer, what the prognosis is, how to stage it. And then for the latter half of the talk, I'll talk about treatment options and long-term follow-up. Some of this may be review for some of you here, but sometimes it's just important to get a new perspective on the same concepts. So what does the thyroid gland look like? The thyroid gland is located in the front or anterior part of the neck. It actually looks like a butterfly shape. So you'll hear a lot of endocrinologists refer to it as the butterfly gland. And it has a right lobe, a left lobe, and a connector piece called an isthmus. So this is important as far as where the cancer is located. On your pathology report, you'll get a location, whether it's on the right side, in the center, on the isthmus, or on the left side. Also near the thyroid gland are these small separate glands known as the parathyroid glands. So these glands are not related to the thyroid directly. They control calcium levels. So it will be important to consider those glands when we talk about the treatment options for thyroid cancer and complications that can occur from those treatment options. So what does the thyroid gland actually do? The thyroid gland produces thyroid hormone. You'll know that there are 2 types of thyroid hormone that we mainly refer to, which are known as T4 and T3. T4 is a more stable form of thyroid hormone and contains 4 pieces of iodine. T3 is the more active form of thyroid hormone, and that contains 3 pieces of iodine. And that's the one that goes and acts on your heart, your lungs, all the different organs in your body. The thyroid gland is actually controlled by the brain, or the pituitary gland. And the pituitary gland produces something called thyroid stimulating hormone. So most of you know this as TSH. The TSH stimulates the thyroid gland to make these thyroid hormones, the T4 and the T3. The majority of the thyroid hormone that's made in the body through the thyroid gland is the T4. It makes a small amount of T3, and then both of these go out to the tissues, the different organs in the body. And the T4 gets converted into T3 when it reaches where it's going. So this whole system has evolutionarily been carefully regulated to make sure that your body has the right amount of thyroid hormone at the right time. If you get too much thyroid hormone, so our T4 and T3, it actually sends a little feedback loop to your brain that says, hey, step on the brakes, we don't need so much thyroid hormone. And your TSH production actually decreases. So we have to remember this concept when thinking about reviewing our lab results. If your TSH is low, that actually suggests that you're on too much thyroid hormone. The opposite actually happens when your T4 and T3 levels are too low from the thyroid hormone you're getting or naturally producing. then it sends a message back to your brain, the pituitary gland, to step on the gas, and it increases the TSH in hopes of producing more thyroid hormone. Okay, so now that we know the basics, I just wanted to quickly review thyroid cancer statistics. So thyroid cancer is actually one of the top 10 cancers that are in the United States currently. Thankfully, as you can see in the bottom half of this, it is not one of the most common causes of cancer deaths, which is actually really good for the prognosis of thyroid cancer overall. So thyroid cancer actually has been increasing from the 1990s to about the early 2010s. There was a significant increase in the rates of thyroid cancer. We initially considered that from diagnosing more thyroid cancer earlier, with the advent of ultrasounds and other imaging technologies being common. But the rate of the mortality of thyroid cancer had not been significantly impacted. So we were investigating other causes of why this thyroid cancer rates have been going up. And then thankfully, since like 2010, 2012, they've actually been stable over the last decade or so. Okay, so the estimated new cases in 2022 will be about 44,000, 2.3% of all new cancers. And then thankfully, the estimated deaths is significantly lower at only 2,200, which is less than 0.5% of all cancer deaths. So what increases the risk of thyroid cancer? There's different things that may increase your risk of thyroid cancer. So gender, as with all thyroid diseases, they tend to be more common in women than in men. But unfortunately, men have a slightly increased worse prognosis from the thyroid cancer. And then age, our cutoff for age is 55. So the older that you get, the increased chance of getting thyroid cancer, with the most common age being about 51. But prognosis is actually based on age, and that was where the cutoff of 55 is. Family history increases your risk of thyroid cancer if you have multiple family members for papillary thyroid cancer, or if you have a rarer type of thyroid cancer known as medullary thyroid cancer, which tends to be genetic and runs in families. And then lastly, radiation exposure to the neck area increases your risk of thyroid cancer, particularly if the radiation exposure was during childhood, when your thyroid gland was growing. We've noticed that decades later, people have a slightly increased risk and more aggressive versions of thyroid cancer. So what are some of the symptoms of thyroid cancer? So actually, most patients have no symptoms. You'd be surprised to believe that a lot of patients don't have any symptoms. If you do have symptoms, you actually get a thyroid nodule, and you can see in the patient over here, that this thyroid nodule is kind of like a lump that appears on the thyroid gland in the neck area. The reason that most patients don't have any symptoms and these thyroid nodules are accidentally found is that a lot of times people get imaging for a lot of different conditions. Say you're in a car accident and you have whiplash, so you get a picture of your neck and that includes your thyroid gland. Or you come into the emergency room because you can't breathe and they're concerned that you might have a blood clot in your lung, a pulmonary embolism. And we get a picture of your chest and it cuts off right at your neck area. So a lot of times we find these thyroid nodules by accident. Some of the other symptoms that you can have is if the nodule is large enough, which is usually 3 to 4 centimeters in size. You can have difficulty swallowing, specifically if the nodule is located on the left side where your food pipe or esophagus is located. You can have breathing difficulties, especially when you lay flat at night. You can get kind of a choking sensation. You can have this neck swelling or lump from the nodule, especially if the nodule is larger or is in the front area. And lastly, some people rarely can get a voice hoarseness. So as you remember from earlier, the thyroid gland is located in the front of your neck. It's near where your vocal cords are. And so a significantly large nodule can compress on the nerves near the vocal cords and cause a change in your voice as well. To diagnose thyroid cancer is based on a biopsy, a fine needle aspiration biopsy. So what do these biopsy results mean? I just wanted to quickly review these with everybody. So if you are to get a biopsy, it can actually come back as non-diagnostic, which basically means that we did not have enough cells. And when that happens, we repeat the biopsy to get a better sample. We can have benign, which is a category 2, which basically means the biopsy showed normal thyroid cells. And what we do with that is we monitor with ultrasounds. We can have a result that shows atypical cells. So these are not normal cells, but these are not cancer appearing cells. So we get repeat testing done with molecular gene markers to help us determine what the risk of cancer is. And then that's a similar for a category 4, which is a follicular neoplasm. Is basically an atypical kind of cell appearance that you get. And then lastly, we have 2 categories. One is suspicious for malignancy, which is probably cancer, but the risk of cancer is about 60 to 75%. Categories 3 and 4 have a risk of thyroid cancer being about 5 to 30%, depending on what they find. And then if we do find cancer on the biopsy results, there's a 99% chance it's cancer. And we definitely recommend some sort of treatment. Usually it's surgery. But also a lot of times we do surgery for a level 5 to determine what it is as well. So once we diagnose the cancer, what kind of testing do we get? So generally, as far as blood test is recommended, a TSH is recommended to see how your thyroid gland is functioning. So the TSH tells us if you're making the right amount of thyroid hormone, if you're making too little thyroid hormone, if you're making too much thyroid hormone. Most people who have thyroid cancer are actually euthyroid, or they're making a correct level of thyroid hormone. Their thyroid has not function has not been impacted by the cancer. Depending on your endocrinologist and your surgeon, a lot of people would recommend getting a calcium level and a vitamin D level as well prior to surgery. And this kind of helps to determine the risk of complications of hypocalcemia or low calcium that you may have after surgery. A lot of times a voice exam, a laryngeal exam is recommended to evaluate your vocal cords prior to surgery. We do that here at Stanford. And then imaging wise, the recommended imaging is a neck ultrasound with lymph node mapping. So a thyroid ultrasound includes just the thyroid gland, and a neck ultrasound includes the lymph nodes that are located outside the thyroid gland. So this is actually very important because if there's concern that there's spread of the thyroid cancer outside the thyroid gland, then your surgical treatment, so the type of surgery, the amount of surgery that you get done changes. So we never want to get in there earlier and just take out the thyroid gland when it's already spread outside, because then we have to go back for a second surgery to get those lymph nodes. Some surgeons may recommend a CT scan of the neck to evaluate those lymph nodes, or if there's concern that there are lymph nodes elsewhere, they might get a CT of the neck to fully see the thyroid gland as well. So for the types of thyroid cancer, there are 4 major types of thyroid cancer that you'll learn about. The most common is papillary thyroid cancer, which is about 80% of thyroid cancers. And this is the first differentiated thyroid cancer. The second differentiated thyroid cancer is called follicular thyroid cancer, which is another 10 to 15%. Those are what I'm going to kind of be focusing the talk on today. There are different talks of ThyCa specifically for medullary thyroid cancer, which is a rare genetic type of thyroid cancer, which can be about 5% of thyroid cancers. The treatment is different than papillary and follicular, as we don't use radioactive iodine in medullary. And then lastly, anaplastic thyroid cancer, which I'm sure some of you have heard about, which is the most aggressive type of thyroid cancer. It's actually a very aggressive type of cancer, period, and it grows overnight. So differentiated thyroid cancer, which is papillary and follicular, tend to be very slow growing, and the treatment is the surgery and radioactive iodine that we're going to talk about. So what are the stages of thyroid cancer? So for cancer, we do a 1 through 4 staging for all types of cancer, and that kind of helps us determine what the long-term prognosis for the cancer is. With generally stage 1 having an excellent prognosis and a 5-year survival of X amount, which we'll talk about, and a stage 4 being a significantly less, a worse prognosis with a less survival rate at the 5-year mark. So for thyroid cancer specifically, stage 1 is that it's located in the thyroid gland itself. Stage 2 is that they're larger size thyroid cancer, or it is involved in the lymph nodes, so it's spread. This is also known as regional spread. Stage 3 is pretty invasive neck disease, and stage 4 is involvement of distant metastatic disease, which is differentiated thyroid cancer is usually into the lungs or the bones. There's one caveat with the staging of thyroid cancer. It is based on age. So younger patients under the age of 55 will only have a stage 1 or stage 2. And stage 1 for them is anything in the neck area, including lymph nodes and pretty extensive neck disease. And stage 2 is spread metastatically everywhere in the body. And that's partly because the prognosis is pretty good for thyroid cancer, especially in a younger population, even if it has spread significantly. The second part that we do of staging is through the American Thyroid Association. And stage, which we'll talk about, is that stage 1 has almost like a 98-99% survival rate at the 5-year mark, but you can actually still have the cancer come back over time. So that is why we do a separate risk assessment through the American Thyroid Association. And you'll hear your endocrinologist talk about 3 risk status. So are you low risk for the cancer coming back, which is usually about 5% or less? Are you medium risk of the thyroid cancer coming back, or intermediate risk, which is usually about 5 to like 20%? Or are you significantly high risk of the cancer coming back, which is over 30%, upwards of sometimes 50% of the cancer coming back? So the risk status, along with the staging, is completed following your surgery. But the important thing is that it's completely independent of staging. So you can be a stage 1 high risk. Usually a stage 4 is also high risk, but you can be a stage 1 low, intermediate, or high risk. And this changes over time with your response to treatment. So if you have a recurrence, you can go from being low risk and have a recurrence and then have high risk afterwards. The way that we kind of differentiated that into overall categories is that low risk is the thyroid cancer is mainly located just in the thyroid gland. Intermediate risk is that it's spread to the lymph nodes, and high risk is that, if there's incomplete removal of the cancer, which is that they're positive margins, or the cancer has distant metastatic disease, that's a significantly high risk of the cancer coming back. So here we talked about the low risk, which is about 5% or less, which involves really, really, really tiny, small lymph nodes, or just mainly it's located in the thyroid gland. And then the majority of the intermediate risk is the lymph node involvement, and high risk patients have incomplete tumor resections of positive margins, a lot of invasion for follicular thyroid cancer. It's extensive invasion of over 4 areas, and then any significantly distant metastatic disease. So what is the prognosis for thyroid cancer? The overall 5-year survival for differentiated thyroid cancer, so we're looking at papillary and follicular, is a 5-year survival of 98.4%. So that is considered one of the best survivals for cancers. Of course, everybody is going to be slightly different. And then the survival is actually located kind of based on staging. So if you have localized stage 1 thyroid cancer, this 5-year survival is almost 100%. And even with regional lymph node spread, which occurs in about 20 to 30% of thyroid cancer patients, the 5-year survival is still 98%. It really does drop off if you have distant metastatic disease, which is, that we talked about the lungs and the bones, that significantly impacts survival overall. So what are the treatment options for thyroid cancer? The primary treatment is surgery. We'll talk about the different types of surgery. If you are intermediate or low risk, which is slightly extensive thyroid cancer, we do use radioactive iodine treatment. And then the third part about treatment is going to focus on thyroid hormone replacement, specifically thyroid hormone suppression. So it's kind of a three-part approach: surgery, thyroid hormone replacement, and then if needed, radioactive iodine treatment. So for the first part, for surgery, this is the best chance that there is for cure. So having a good surgeon that does a lot of thyroid surgeries is important. It not only decreases the rate of having complications from the surgery, but it also increases your risk of getting a good surgery, primary surgery, and a good chance of cure. So there are three different terms that we use for surgery. A lobectomy is just taking out half the thyroid gland. So if you have a small nodule which has cancer of like 1 centimeter or less, a lot of times we do a lobectomy. And unfortunately, we can't just like carve out around the nodule. So we do take out half the thyroid gland, and that's the half that the cancer's on. You can actually also do it for any cancers that are up to 4 centimeters located on one side. The best outcomes are of micropapillary, which is less than 1 centimeter. And but this we only use for cancers that have not spread to the lymph nodes. If your cancer has spread to the lymph nodes, generally we recommend a total thyroidectomy, which is that we remove both sides, and a neck dissection. So there are two terms for this, which is a central and lateral neck dissection. So the central neck dissection is lymph nodes that are located in the center part in between the two lobes of the thyroid gland. A lateral neck dissection is located to either side. On the outside, you can have a right lateral neck or a left lateral neck dissection. And that is really to remove any extra lymph nodes that have spread outside the thyroid. So what are the risks of surgery? You may need thyroid hormone replacement. So ideally, the goal TSH for patients who have thyroid cancer is less than 2. A lot of times we do lobectomies to prevent people from getting on thyroid hormone, or to ensure that you need a little bit less thyroid hormone and you have like half a functioning thyroid gland. But a lot of people with thyroid cancer still need thyroid hormone replacement. And the other two things that we consider with risk of surgery are hypoparathyroidism, so damage to those parathyroid glands. We talked about how those parathyroid glands are kind of embedded behind the thyroid gland. And sometimes when we remove the thyroid gland, they can come out with the thyroid gland, or your blood flow can get a little disrupted because things got moved around in the neck area. So up to 10% of people can actually have low calcium levels following their surgery. Thankfully, it tends to be short term, usually a couple weeks to a couple months, and then they recover. The long-term permanent hypoparathyroidism is usually less than 1%. And that's, we wait an entire year to see if your parathyroid glands will have some sort of recovery before we consider you to have permanent hypoparathyroidism. The second part specifically with these type of surgeries is damage to your laryngeal nerves. So as you can see, the laryngeal nerves go right outside where the thyroid gland is. So those can get damaged as well when we're doing surgery. And that can lead to voice problems. If that occurs, speech therapy is what we use. It's kind of like physical therapy for your voice. We kind of retrain your voice to help with those voice problems. And that, again, is more common transiently, and then it gets better over time versus being permanent paralysis, which causes like long-term voice hoarseness. And then, of course, the other risks are with all surgeries. You can have a risk of anesthesia side effects, bleeding, or infection. But these specific ones are related to thyroid cancer and thyroid surgery. Sorry, this is where the recurrent laryngeal nerve was. Okay, so the second part of the treatment that we talked about was radioactive iodine. So what is radioactive iodine? This is a targeted treatment that's used after a total thyroidectomy surgery. So it's not used in patients with a lobectomy. And it's basically where we give you iodine. So we talked about how iodine, the thyroid gland has iodine in the thyroid hormone. So we specifically from the outside are giving you this pill with iodine in it, and it has a little bit of radiation activity attached to it. So when the thyroid gland takes up this iodine that we've given it with radioactivity attached to it, it actually kills off that cell. So it's used to treat any thyroid tissue that's left behind. This is what we call a remnant ablation. It is used to treat thyroid cancer that's in the lymph nodes. It's a little bit less effective, or can be less effective, but we do still use it. And it's used to treat metastatic disease, specifically commonly to the lungs. So it will treat those lung nodules. The doses that are recommended are usually determined either by the endocrinologist with the nuclear medicine specialist or the nuclear medicine specialist. And the doses can range from 50 millicuries to 200 millicuries. The dosing generally depends on the amount of thyroid cancer that was present, the staging, if you've gotten a previous dose or not before. So there's a lot of factors that go into determining the dose, and each dose is individually made per person. So we can't tell you ahead of time what that specific dose is going to be. A lot of institutions kind of do a pre-scan of the whole body before we give you the radioactive iodine treatment. And that's to help determine if we think the cancer has spread anywhere or how much of it's still remaining, to help tailor the dose to each individual. And this is specifically used because it decreases the risk of recurrence and death in thyroid cancer patients. What we found over the years, so traditionally, you might know people who've gotten thyroid cancer treatment 20, 30, 40 years ago. And we used to say that, no matter how small the cancer is, we would give everybody a total thyroidectomy followed by radioactive iodine. In the last decade or so, we've kind of shied away from doing that. And now we just target it towards intermediate and high risk patients. We found that low risk patients don't really have the same kind of benefit for the long-term mortality that was associated with thyroid cancer. So we've stopped giving radioactive iodine to that group of people. So do you need radioactive iodine treatment? As I was saying before, this is used for patients with intermediate to high risk only. The treatment takes about 6 to 12 months to work. And it's usually a one-time dose, but however, we can use it multiple times. There is a lifetime max that's somewhere between 600 millicuries and 1,000 millicuries. It depends on each individual patient. So this is to prevent any sort of significant long-term complications of secondary cancers from the radiation treatment. So what we do is we kind of use each dose that you get, and it adds on to the next one if you require multiple doses. But most people, it's usually a one-time dose, and it does require some isolation. So we recommend that usually 3 to 5 days following treatment that you isolate yourself from other people, use your own restroom, sleep in your own bed. If that's not possible, we do sometimes bring patients in the hospital for that isolation. And there's usually a preparation that's required. So it's not like other scans where you can just kind of show up to the hospital and get your imaging. There's a preparation that's required. We do ask that people do a low iodine diet prior to the scan so that the iodine that we give you is more effective since you've depleted the body of all its natural iodine. And then in order to get the scan done, you need to have a high TSH level. We can do that for you from the outside synthetically by giving you TSH injections, which you'll learn are thyrogen injections. Or you can do it the old-fashioned way, which is to stop your thyroid hormone for about a month and let your TSH naturally rise. This is to stimulate any sort of remaining cancer cells that might be still around to pick up the iodine that we're giving it with the radioactivity. And so how do you prepare for the radioactive iodine treatment? So I was talking about that there's 2 ways, which is the first way is the withdrawal, which is what we used 20 years ago. That's the stopping your thyroid hormone dose. If you've known patients who had thyroid cancer a long time ago, they'll talk about how they did this repeatedly every year to get a scan. We don't do those scans every year now, thankfully, as well. Some institutions may recommend that you take T3 Cytomel for a short period of time to kind of help ease those symptoms. So for those of you who've done withdrawal, you do get hypothyroidism symptoms, especially that last week before the treatment. And the cytomel kind of helps, prevent those kind of those symptoms that you may have. And then those thyrogen injections are 2 injections that are done right prior to the day, 2 days before the radioactive iodine treatment. And then we do a low iodine diet for 2 weeks. Your endocrinologist and nuclear medicine doctor, your team will decide what type of preparation is recommended for you. Generally, most people get the thyrogen. Withdrawal is usually only reserved for significantly high-risk patients, and some endocrinologists actually don't do withdrawal at all because of the risk of the hypothyroidism. And so each person is going to kind of have a tailorized treatment plan as far as this preparation, what dates they have to do these at. But this is kind of the overall general concept regarding it. What are some of the side effects of radioactive iodine? Radioactive iodine is generally considered pretty safe as far as the treatment, but there are some side effects. So I did want to briefly cover those. So a lot of people will describe having a taste change, usually following the radioactive iodine. This tends to be temporary, so people describe having a metallic taste, or they can't taste their food as well. It usually goes away in the first couple of weeks. Xerostomia, and this is actually known as dry mouth. This can be a long-term complication of the radioactive iodine, and this can sometimes lead to cavities. So it's important that if you do have dry mouth to check in with your dentist regularly. Those are probably the most common. The nasolacrimal duct obstruction. So there's a tear duct blockage in your eyes. So this uses a little bit of iodine and you can cause a blockage, and that basically causes your eye to appear to be tearing excessively. This is fixable. So that basically is fixable with the surgical stent procedure that an eye doctor can place in. Pulmonary fibrosis, so this is basically lung scarring, and this is only really happens in patients who have a lot of distant metastatic disease to the lungs, and we use a pretty high dose of radioactive iodine. So this is considered, one of the reasons we may not use such a higher dose in lung patients, depending on how much activity they have in their lungs. Bone marrow suppression, so it does decrease the white blood cell count. It's temporary for a lot of people, but can be permanent. And then I know one of our other physicians is talking about the secondary cancers. The risk is pretty low with 1 dose. And as I was talking about earlier, there's kind of a max lifetime dose of radiation treatment that we would recommend to prevent this. And I'm sorry, I forgot to cover one other side effect that is on the common side, which is a salivary gland stone. So along with dry mouth, you can actually get a stone in your salivary gland, which can cause a little bit of pain and swelling. This stone will naturally pass, but if you're getting a lot of stones, or for some reason the stone can't come out, that is also treatable with surgery as well to kind of remove the stone. Okay, so for the third part of treatment, how much thyroid hormone do you need? So we give people thyroid hormone to suppress their natural production of thyroid cells that may be remaining in the body. And this is to really prevent any cancer from coming back. That's the goal of it. So a normal TSH, depending on the lab, can run anywhere from 0.5 or 0.4 to 4.5. Again, this depends on the lab, and all institutions have different labs. It's important to look at what the reference range is for your lab. The patients who are low risk, which cover the patients who get a lobectomy, the goal TSH is 0.5 to 2.0. So we're keeping low risk patients in the bottom half of normal. Intermediate risk patients are slightly suppressed. So this is like kind of known as moderate suppression, which the TSH goal is right below the normal of the reference range, but isn't 0. And then high risk is the suppressed TSH of 0. So there are side effects of thyroid hormone, which is why we don't give everybody extra thyroid hormone all the time. So when we go back 20, 30 years, a lot of patients had extra thyroid hormone. Even if they had a small cancer, they were low risk, they got lifetime extra thyroid hormone. So what we found over the years is that there are a lot of risks associated with this. So as thyroid disease mainly occurs in women, osteoporosis is also a disease of women largely, and that is basically a low bone density, which increases the risk of fracturing. So the extra thyroid hormone actually depletes, physiologically kind of makes the bones a little bit weaker and can cause them to fracture. Another thing that it does is that it acts on the heart, and so it causes the heartbeat to increase, and sometimes this can lead to atrial fibrillation, which is also known as an irregular heart rate. And if you get atrial fibrillation, you have an increased risk of stroke. So we don't want to cause more damage than what the cancer is going to cause itself. It can also cause heart racing, which is basically palpitations. It can cause shaking in the hands, which is tremors. So people can get a little bit of tremor. And it can cause a lot of mood disturbances. So people can get anxious, short-tempered, or have problems sleeping at night. And if you're getting any of these side effects, it's important to talk to your endocrinologist about what the appropriate dose of thyroid hormone is for you. Because it's a balance to make sure that you are treating the risk of the cancer coming back versus getting any of these side effects from the extra treatment. For the latter half, I want to talk about some other terms that you might hear about. So thyroglobulin, TG, is the tumor marker. So thyroglobulin is a substance, a protein that's made by thyroid cells. So it's important to know that in lobectomy patients that we remove half the thyroid gland, they will all still have a detectable thyroglobulin level. If your whole thyroid gland is removed, thyroglobulin levels should be low, if not zero. Ideally, we would like it to be zero, but even with the best of surgeons, it can still sometimes be a small detectable number. The main thing is that increasing thyroglobulin levels, so that number is increasing with time, there's a concern that there is a growth of cancer. The other important thing to remember is that there are antibodies to thyroglobulin that are produced in about 20 to 30% of patients. And basically, if you produce these antibodies, it makes the thyroglobulin test less reliable. So sometimes we will send the thyroglobulin assay to a different institution to see if we can get rid of the antibodies, or we will use the antibodies as a substitution for the thyroglobulin level. So if the antibodies are going up, there's concerns that there might be a cancer recurrence. What is the long-term follow-up for thyroid cancer? So one of the things that we look at is the TSH, which tells us the dose of the thyroid hormone that you're taking. Is that a good dose for you? Is there too much thyroid hormone? Is there too little thyroid hormone for the amount of risk status that you have? We use the thyroglobulin blood test tumor marker to check to see if there's any cancer recurring. We have thyroid ultrasounds, which are pictures of your neck, similar to what we did with the nodule, but this is basically looking for if there's any lymph nodes or any cancer coming back. We do use the whole body scan in patients who've been treated with radioactive iodine, or if we're concerned that the cancer has spread elsewhere, we will get a whole body scan. And if you have advanced thyroid cancer that is refractory to radioactive iodine, so the radioactive iodine no longer works, we do use PET scans and or CT imaging to follow any sort of distant metastatic disease. What if your cancer comes back? What are your treatment options? So active surveillance is a term that's used for monitoring. If you have a super small, tiny amount of cancer, or if you have an indeterminate, something pops up, a small little lymph node that's too small to biopsy, or a thyroid bed spot that's too small to biopsy, we will do something we call active surveillance, which is monitoring it. If it's really tiny, it can sometimes be hard to treat. It can be hard to pick up on the radioactive iodine scan. It can be hard to remove surgically, which is why we do the monitoring and we wait for a good time for treatment. We can do more surgery. So if it comes back, we can remove it again. We can do more radioactive iodine treatment. So most people get one dose, but we can use multiple doses, 2 or 3 doses. And then very, very, very rarely, if it comes back multiple times and is aggressive, we can use radiation called external beam targeted radiation therapy. Again, this is for advanced thyroid cancers to the neck area. We can also use chemotherapy. The chemotherapy is not currently curative. So it's a target mutational based chemotherapy. So we'll check your gene mutations and target the chemotherapy. But again, it just kind of controls the cancer. It doesn't cure it in traditional chemotherapy where you come in for infusions for a certain amount of time. And then if the cancer's gone, you get off the chemotherapy. Thyroid cancer chemotherapy is actually lifelong. It's a pill that you take at home. So we don't hand it out very lightly. We use it in certain circumstances only, and that's generally less than 1% of patients with differentiated thyroid cancer, papillary or follicular thyroid cancer. Now, anaplastic thyroid cancer is used more frequently, and in medullary, if you have advanced medullary, it is used a little bit more frequently. Okay, so what resources are available if you do have thyroid cancer? So the American Thyroid Association puts out patient information regarding thyroid nodules, thyroid hormone replacement, thyroid cancer treatment. There is the NCCN Foundation, which is the National Comprehensive Cancer Network. They also put out significant patient information regarding thyroid cancer. And lastly, this group, ThyCa, where majority of the people do get patient information, as well as survivorship groups and local support as well for having thyroid cancer. Okay, so what should you take away about this talk about thyroid cancer? So thyroid cancer can have no symptoms. If you do have symptoms, it's usually a lump on your neck area. You need an FNA biopsy of a nodule to diagnose thyroid cancer. The treatment for thyroid cancer includes surgery, either a lobectomy, so that's half the thyroid gland, a total thyroidectomy, which is the whole thyroid gland, or a neck dissection, radioactive iodine, and thyroid hormone replacement. And the more aggressive your cancer is, the more that you're going to get radioactive iodine treatment and the more thyroid hormone that you're going to get. Treatment is a personalized team-based approach with your endocrinologist and your surgeon and a nuclear medicine doctor if you need radioactive iodine. Sometimes it can come back, and we have the same treatment options as the initial diagnosis, which is the surgery and the radioactive iodine. But overall, even if it does come back, thyroid cancer has differentiated thyroid cancer, follicular and papillary, has an overall excellent prognosis. Okay, so I want to spend the last 15 minutes answering any questions from the audience. Yeah, I know that was a lot of information, so people might have some questions.
We do. We have a question from someone who said they had a recent thyroid lobectomy. Pathology noted, quote, papillary thyroid microcarcinoma, follicular variant, infiltrative, unquote. What does all that mean? Is it mostly papillary, mostly follicular, capsulated, non-encapsulated? Is infiltrative the concerning word? What do you help on this?
Okay, so there's papillary and follicular in the traditional categories. There's a small group of something called follicular variant of papillary thyroid cancer, which acts more like papillary thyroid cancer than it does follicular thyroid cancer, which is why it's grouped with the papillary. Infiltrative is kind of, I would need more on the pathology report to explain kind of what infiltrative is, because it can mean different things to different people. What they generally look at is if there's how much infiltration there is. So with follicular thyroid cancer, they look at all the spots of infiltration. So they should give you a number, whether it's less than 4 or more than 4 blood vessels, but I'm not sure if they'd use that for the if it's follicular variant papillary. So it would have to be a conversation with the patient directly to be more effective, but try to answer it.
No, that's good. Thank you. So we have another one. I had a total thyroidectomy and took 175 MCI earlier. What are some possible complications of taking the RII and cancers associated with that down the road?
So with 1 dose of radioactive iodine, there's not a significant risk of secondary cancers, but there is actually one of our physicians at Stanford is going to actually talk about the risk of secondary cancers at one of the other talks here. But mainly the concern is that if you get excessive amounts of radioactive iodine, it is a form of radiation, so you can get leukemias and lymphomas, which are bone malignancies. There is a slightly higher risk of stomach cancers because the radioactive iodine sits in the stomach before it gets dissolved. And there's some question about whether there's an increased risk of breast cancer because the breast tissue does take up iodine. So it can be targeted in the breast tissue as well in some patients. But the exact risk is very different based on each and every person individually. So that I can't tell you an exact risk of a secondary cancer happening, but generally with one treatment, it's the risk-benefit ratio of the thyroid cancer being treated is more important than a secondary cancer down the line.
Okay, thank you. And we have another question. What size is required for an FNA on a lymph node?
Generally, we don't biopsy anything less than 0.8 centimeter. So about a centimeter, a little less than a centimeter on the smallest dimension is what's currently recommended in guidelines. And that's partly because it's very difficult to find that surgically. When you go in there, it's hard for a surgeon after you've had a first surgery to find something so small on a second surgery when everything is a little bit different.
Great. And you talked about RAI overall. How much iodine, radioactive iodine, can a person receive overall? Like what was the max amount?
So this is a debate between endocrinologists and nuclear medicine physicians, somewhere between 600 millicuries and 1,000 millicuries. It depends on how much your body personally can take. So there is something that if we need to use multiple doses, we could consider it's called dosimetry. So the nuclear medicine doctors will see how much your basically bone marrow can take of the radioactive iodine. So again, that's a big range between 600 and 1,000 millicuries.
Okay. And how often and for how long do you have recommend follow-up testing done? Thyroglobulin, ultrasound, that's sort of annually, question mark, for, for how many years?
So this actually depends on two things, is what was your original risk when you had your first treatment. Obviously for higher risk patients, we do more long-term follow-up, more frequent follow-up. Sometimes it's like twice a year, it can be 3 times a year. It also depends on what kind of response to treatment did you have. Like, were you cured? Is there a small indeterminate nodule still there? Do you have some little bit of thyroid cancer left? So in that spectrum, the more that's physically there, the more frequently we're going to follow you with thyroid globulins and ultrasounds. A lot of times we follow low-risk patients once a year. I do recommend at least getting a TSH and a TG level once a year. The ultrasound you can get done periodically. But absolutely, for sure, you have to monitor what level of thyroid hormone you're taking, because things can change and you can require less or more long-term, which is why we get the TSH. And then the TG is just kind of a screening to see if the cancer is still gone.
Okay, we have a question about someone with papillary thyroid cancer was told they have tall cell variant. Was the follow-up different? Is the recurrence different? Is the treatment different?
Yes. So the variants actually are somewhere between intermediate to high risk, depending on the variant type. Tall cell tends to be a little bit more aggressive and has a higher rate of recurrence for the papillary thyroid cancer. So generally, we do use the radioactive iodine. We give extra thyroid hormone for tall cell variants, and we monitor more frequently for recurrence because they do have a higher rate of recurrence.
So is thyroid?
I answered your question.
Sorry, wait, is thyroid cancer linked to any other endocrine cancers?
Not specifically for differentiated thyroid cancer of papillary and follicular. But that being said, is that if you have mutations that lead to one cancer, a lot of times you can get another cancer that just happens to be there. A lot of people get breast cancer and thyroid cancer. Some people get colon cancer and thyroid cancer. There are some genetic mutations, like a P10 mutation, that can cause multiple cancers to run in families, with thyroid cancer being one of them.
Okay, and what do you think about radiofrequency ablation?
So radiofrequency ablation is pretty new here in the United States. I know they've been using it internationally for decades. The data with radiofrequency ablation and thyroid cancer is for micropapillary thyroid cancers, which is usually less than 1 centimeter. There have been some studies that have been done, at least short-term wise, it seems like a pretty good response to treatment. We just don't have what happens 10, 15, 20 years down the road as of now. Eventually, we will get that data, but currently it's not considered a standard of care for thyroid cancer. And that might change. I might come back here in 5 years and be like, oh, this is another treatment option now, but currently it's not a first line.
What about BRAF? Do their presence impact treatment and prognosis too?
So there is, yes, BRAF mutations are used for a lot of different things. You can have a slightly higher risk of recurrence with the BRAF mutation. Doesn't mean you'll get a recurrence, but we do sometimes monitor people a little more frequently. There's some question about the radioactive iodine being slightly less effective in BRAF patients, but again, each individual is different. And then we do use it for targeted chemotherapy if it becomes advanced thyroid cancer.
Okay. Is it necessary to have a central dissection if there is a left metastasis?
Is a central neck dissection if there's a left-sided neck metastasis? Yeah. So this is actually where the ultrasound imaging comes into play. Not necessarily, but it depends on where those lateral lymph nodes are. Sometimes, a lot of times the surgeon will do a same left-sided central neck dissection, but you don't necessarily need it, especially if that central area is clean on the ultrasound.
And what would be considered normal treatment, normal medication treatment after a thyroidectomy? Naloxone, Synthroid, et cetera, what do you recommend at your practice?
Okay, so there are a couple of different brands of thyroid hormone. I'm sure all of you probably have heard of brand name versus generic. The generic is levothyroxine. Brands, the most common brand is probably Synthroid. Levoxyl is another common brand. Unithroid is there. There's a special version that's used largely in Europe called Tyrosine, and it's a gel cap version. They also have Tyrosine Sol, which is liquid thyroid hormone that comes in a little packet that you pop. Unfortunately, brand name and specifically Tyrosine a lot of times tends to be more expensive than generic. There've been a lot of studies that have looked at generic versus brand name. Most of them, a lot of times people are okay with generic. If it's causing too much fluctuation in your thyroid hormone levels, then for sure try the brand name because it tends to be a little bit tighter control. If you have things like celiac disease, there is gluten in the generic and Synthroid. So Tyrosine is the one that's recommended for gluten-free, and it does tend to absorb a little bit better than some of the other brands. But it depends on many circumstances. If I don't necessarily always say that brand name is the only recommendation. Okay.
So I have a question from someone they're anonymous, and they said, we have a patient who underwent a lobectomy due to a nodule. Histopathology of the nodule resulted in diagnosis of thyroiditis, but a 7-centimeter no encapsulated papillary carcinoma was found in the lobe. Do you prefer the follow-up be carried out, or should a total thyroidectomy be done?
Just to clarify, it was 7 centimeters, not 7 millimeters, right?
Sorry, 7 millimeters. Yeah.
Oh,
7 millimeter, no encapsulated papillary.
It's 7, so it's under 1 centimeter, right?
Yeah. Right.
Yeah. Okay.
Half a centimeter. Yeah.
Yeah. Okay. So if it's under 1 centimeter, you don't necessarily have to go back on the other side. There is one caveat with that ultrasounding. Somebody with thyroiditis can often show a lot of indeterminate lymph nodes or pseudonodules on the other side. So it can be slightly difficult to monitor, but generally we do recommend, you get lobectomies for under 1 centimeter anyway. So I think it can be monitored with the lobectomy.
Okay, if I have differentiated thyroid cancer and is slow growing, can you give me an idea of how long a 3.5 centimeter follicular thyroid carcinoma would have been growing?
I can't tell you the exact time, but generally it's years. I would say it's not months, it's years.
It's years. Okay. So, and I would say, yeah, don't rush into anything. It's been years growing. Do your research, get a second opinion, right?
Yep.
Don't do it tomorrow. So, okay. Thank you. Thank you. And I think we have time for one more. How long are you monitored and tested before you can be considered, quote, cancer-free, unquote?
It depends on what your response to treatment is. So if you have an excellent response to treatment, then you're technically cancer-free because you've had a good response to treatment. And that can be usually done within 6 to 12 months following your initial treatment, depending on whether you got radioactive iodine or not.
Okay. I took 200 MICI, and one of the side effects was my tongue turned purple. Is that normal? My doctor seemed shocked, claimed he had never seen that before.
I have also never seen that before, so that would be a first for me. I'm not sure if you had some sort of reaction to the dye from the 200 millicuries, because they are dyed unless you're getting tyrosine, which still has a dye, it's yellow dye. I'm not saying it's not possible. Any sort of side effect, I've been around long enough to know that all side effects are possible from medications. So I'm not saying it's not possible, but I've never seen that.
Okay, and this will be our last one. I've been having some insomnia since my total thyroidectomy I never had before. What do you advise when the TSH is normal?
Is it actually, so this is kind of difficult, is that what is your insomnia from? Is there, are you concerned about, you know, recurrence? Is your insomnia, it's hard to say if it's from the thyroid hormone, if your TSH is normal. You could try reducing the dose slightly by half a tablet and seeing if the insomnia improves. But a lot of times the insomnia is from something else if your TSH is not fully suppressed.
Okay, and is there another thyroid medication that helps with weight gain post-thyroidectomy?
Unfortunately, no. No. None of the thyroid hormones should be used to cause weight loss after thyroidectomy. We are definitely overtreating you with significant side effects if you're getting severe weight loss from the thyroid hormone. There are other medications, specifically weight loss medications, that do have a better side effect profile and a better like actual weight loss. So if you did want to work on your weight, I would recommend one of those.
Okay, thank you. That's wonderful. Would you like have any comments or summaries to leave us with before we end the session?
I would just consider this a journey. It's a marathon. It's not a sprint. So it's important that you're looking at the long term, not necessarily just the short term when considering your thyroid cancer journey.
Thank you so much for your presentation and your answering our questions and everything. And thank ThyCa for having us. And thank you all for coming.
Thank you.
To see this, to learn about our, like you said, our journey. So thank you very, very much.
Thank you so much.